Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome to another episode of the Oncology Revolution Podcast. Today's conversation is one that highlights an area of cancer care that is finally starting to receive the attention it deserves: oncology rehabilitation and survivorship. For many people, cancer care is still viewed exclusively through the lenses of surgery, chemotherapy, radiation, or medication. But what happens to quality of life, physical function, fatigue, movement, identity, and long-term well-being during and after treatment? To explore this, we have here today with us Deborah Doherty, an oncology rehabilitation consultant and educator, a physical therapist, an author too, integrative nutrition health coach, and researcher. Deborah has dedicated much of her work into helping reshape the way we think about recovery, rehabilitation, exercise, and supportive care in oncology. She's also a co-author of the textbook Oncology Rehabilitation, a comprehensive guidebook for clinicians, which we'll get into in a second. Deborah, thank you so much for being here with us today. What first drew you into the field of oncology rehabilitation and survivorship care?
First of all, thank you for allowing me to come here today. This is a wonderful opportunity, so I appreciate the invitation. And I am thrilled to share with you that as of June 27th of this year, that will be my 20th year cancerversary. So 20 years ago, I was actually diagnosed with breast cancer, and I had a mastectomy on June 27th. And I always tell patients, come up with a day you can celebrate, whether it's the day of diagnosis or the day of surgery or when your treatments. I mean, you decide that date because we need to celebrate the life we have. And so that is really my beginning into oncology rehab. I was not trained in oncology rehab as a entry-level physical therapist many years ago. But from that point on, with my own diagnosis and seeing the gaps in care, I had a wonderful surgical oncologist, wonderful medical oncologist, but no one talked about the adverse effects. And they didn't tell me anything about treating the adverse effects. I had to figure that out on my own. And I realized within the area that I live in the state of Michigan in the United States, there were no oncology rehab programs. So I made it my mission from that point on, and my purpose in life for the last 20 years has been to work to bring oncology rehab education, awareness, and help survivors in any way that I could through educational programs, through talking to support groups. I went to every conference that I could go to, learned everything that I could, and then I started teaching and treating patients. And we'll talk about some of the programs that I have set up during my time, and then writing our textbook. So that's really been my journey.
I think what's so interesting about this field is that many professionals enter it almost by accident, and for you, it was from your own diagnosis. But then they realize how enormous and the unmet needs really are. Was there a specific defining moment in your career that just made you realize, okay, this rehabilitation really needs to become a much bigger part than it actually is at the moment in cancer care? Was there a specific moment that this clicked?
I mean, it really was with my own diagnosis. When I saw the gaps in care, not only for myself, but then looking around and realizing all the patients that had cancer diagnosis in their history and were suffering needlessly with all these adverse effects, and realizing there's so much we can do. There's so much out there that we can do as rehab clinicians, and whether it's physical therapists, occupational therapists, exercise physiologists. I mean, there's a lot of us, a lot of different professions that can work with this population and bring quality of life to them. So I just dove in headfirst from that point.
And despite how essential it is, and it sounds, once we start to talk about it, rehabilitation still feels invisible to many oncology settings. Many people, as I said earlier, still associate cancer mainly to surgery, chemotherapy, and its different treatments. Why do you think rehabilitation is still under-recognized in oncology?
Well, I think it's really multiple causes or very multifactorial. It's not just one thing. And I think it goes back to, historically, oncology rehab in my early career, the only thing that was looked at was lymphedema. That was the only thing that was treated. And back then they were, in my early career, they were removing many more lymph nodes than they do now. And so they're causing huge amounts of lymphedema. That was the only thing that was treated. But now with medicine, doing wonderful things and survivorship at an all-time high, we're recognizing the importance of long-term survivorship, of the need for good functional outcomes and quality of life. So it's kind of been this slow, evolution. But I also feel there's, many different stakeholders that need to be playing a part in this. A lot of it has to do with education and training. First of all, you have physical therapists or other clinicians who don't have a desire to work with this population. So we have to find the therapists who want to work with this population. Then we have to educate them, because many therapists are not educated or trained in working with patients diagnosed with cancer. That education is essential. Then we have to bring awareness to physicians and physician extenders and insurance companies and administrators to understand the benefits of oncology rehab. We also have to make it easier for referrals. So here there's, electronic medical records are now, prevalent throughout all the healthcare systems. And so there's ways that we can work with the electronic medical records to make it just a click away to refer, because referrals are not where they should be. We aren't getting the referrals we need. There's huge amounts of research. It is wonderful, the amount of research that's out there showing the benefits of oncology rehab, but it's not been disseminated well to all of those stakeholders, to make sure they understand, again, the benefits, and we have the proof, the evidence of the benefits. But I'd like to go back to the education part, because there's actually two levels of education we need to deal with. First, we need to deal with entry-level programs, entry-level physical therapy, occupational therapy, speech language pathology programs. The entry-level programs, making sure they have the right training, the right information, the baseline data necessary to work with this population. And then we have clinicians out in the community, lots of clinicians out in the community who were never trained and who also need to be educated. So we have these two areas that need work. I've just been blessed with working with wonderful colleagues in both of those areas. So at Oakland University, where I teach, and I'm now semi-retired from there, but I teach in what we call the Graduate Certificate in Oncology Rehab. Now, this is an totally online program for physical therapists, occupational therapists, again, speech language pathologists, exercise physiologists globally. So we have students from all over the world that are part of this program. It's teaching clinicians that are already out there that know their specialty how to work with patients diagnosed with cancer, how to look with patients. We're just looking at them with different eyes. We're not teaching them how to be therapists. They know that. They have the skills. They just have to understand the diagnosis and the adverse effects. So our program is doing very well at Oakland University. And it's not just us. There are programs popping up all over for training. But we also need to be training at the entry level. So entry level programs, like in the United States, our Doctor of Physical Therapy entry-level programs, they've not had specific requirements for education regarding oncology rehab. Now, that's in process right now. In fact, our Academy of Oncological Physical Therapy, through our national association, the American Physical Therapy Association, has now created guidelines and criteria for every entry-level program in the United States, the baseline information that needs to be included in every program. And that's, in the works right now. So that's wonderful. One of my colleagues, Dr. Lori Bowright, and I created a modular we call it our foundational oncology rehab program. We have been working on this for approximately 8 years now. We created this program to bring this information to all the DPT programs right here in the state of Michigan. And it's just been wonderful. We've been able to take this foundational information to each of our programs in Michigan and then, not only teach the students, but help the faculty to understand what is the baseline information that is needed. And from there, we have been able to now take that globally. So we've been working with some wonderful colleagues and taking our foundational program to a couple of different places in South Africa. We've also taken it to a couple places in Bosnia. We are working with a group out of Lebanon now that we should be presenting that, or they should be presenting it by the end of the year. And we're working with some other states in the United States. So we're just really thrilled to be working with both of those areas. And again, there's other folks doing that too. It's just been really a wonderful experience to bring this education to everyone that needs it. And that will help improve awareness of oncology rehab.
Yeah, totally. One of the reasons this conversation matters so much is too because many people finish treatment believing they simply have to live with whatever comes next. In your point of view, what are some of the most common physical and emotional challenges people experience during and after treatment that often go unaddressed?
So I'm really glad that you asked me that question. And I brought our list of the dirty dozen. That's what we refer to when we are teaching in all of our programs. There are many adverse effects that can occur from the treatments for cancer. And we do not know who's going to get which adverse effects. That's what we try to tell the physicians as well as patients. We don't know what adverse effect you're going to get. That's why we need to educate you on these adverse effects. But what we call our dirty dozen, the ones that are the most prevalent adverse effects that we see in the community are fatigue, chemotherapy-induced polyneuropathy, chemotherapy-induced cognitive impairment, huge cognitive impairment out there, sarcopenia, balance issues, lymphedema, of course, either generalized weakness or specific muscular weakness, radiation-induced fibrosis, decreased motion, decreased joint motion, pelvic floor dysfunction can be huge, scar adhesions, and then also all those psychosocial issues, the depression, the anxiety, the fear of movement is huge. And also just, poor body image. So those are the most prevalent. But whether they're addressed or not is really just sporadic that we're seeing. There are some clinics and some hospitals that are right on. They are referring patients to rehab in acute care. They're referring to outpatient, but it is not anywhere a standard of care and not across the board. It depends on the hospital system, depends on the physicians. So there are many folks out there who are not having those adverse effects addressed and suffering severely from it. And patients don't complain. They're so happy to be alive that they're not going to complain about what they're dealing with. They just figure, I've got to live with it. And we need to change that. We need to educate patients on the potential adverse effects. And this is what you need to look for. And it's about early detection. The earlier we can treat you, the better your outcomes are, the less suffering you have to do. So it's really all about that prehabilitation work that we need to do. Prehab being, I want to see somebody before they start treatment. I'm going to do baseline measurements to see where they're starting from. I want to educate them on all the adverse effects and set everybody up with an exercise program. So I hope we talk about exercise later because that's a crazy thing that I'm very involved with too.
Yeah, we'll get into that in a few. Fatigue, you mentioned fatigue, and it's probably one of the most talked about symptoms and after treatment and during treatment too. Does it becoming completely life altering? It's a different kind of fatigue, as many reports. Many survivors assume fatigue, pain, weakness, or mobility limitations are simply part of the process. As you said, they're happy to be alive. How do we change this mindset?
Well, it's a great question, and we struggle with this all the time. It's again starts with education. It's educating the patients themselves. This is why we want oncology rehab. I'm going to repeat this several times to be standard of practice. So that every person that is diagnosed with cancer at least has a consult with an oncology rehab, um, clinician, because we can educate them on these again potential adverse effects and help them to understand how to not only how to manage them, prevent them, decrease the severity of them, and when to call us. Because as myself, my adverse effects didn't occur till 3 years following my diagnosis. And so they don't always happen right away, but patients need to understand that. The other thing I really wish would be happening on a regular basis is patients see their physicians regularly. At every physician visit, they should be asked these questions, whether it's through a survey, fill out a little paper, or asking the quick questions about those, specifically those dirty dozen, because patients will forget about what they've heard, and unless they're feeling the effects or experiencing any of those adverse effects, they might not think about it, but they need to be asked every time, because some of those effects don't happen till later. And again, we need early detection and early treatment. So if we can educate the patients and have them ask frequently, throughout their time of treatment, if they are having any problems, then we can catch it early.
Sure, totally. And sometimes it's not even just on the side of the patients and what they believe. It's also, and you've mentioned before, on the side of healthcare professionals that historically have been taught how to do their work, but not exactly. It's always evolving in oncology too, in cancer care. So they're not always up to what it should be, or how can we help the patient better. In your opinion, what are the biggest misconceptions healthcare professionals still have about exercise and rehabilitation in oncology?
Well, this is one of my passions. So I'm glad we're talking about this, because I really believe that as oncology rehab professionals, we have not done our job right. We have not done a good enough job helping the patients and helping the medical community understand exercise. I like to refer to it as movement. So movement is medicine, and we need to move every day, 365 days a year. I don't care what a patient's age is. I don't care what their diagnosis is, the stage, the grade, where they're at in their journey, whether they're in hospice or palliative care. People need to move every single day, 365 days a year. And we have not done a good enough job explaining that. So what I mean by that is we talk about movement in three different ways. There is exercise, which is structured movement, which is very targeted movement. We have specific body parts that need work on. Our cardiopulmonary system needs work. Yes, we need specific structured exercise programs. We also need patients to know that physical activity is just as important. Physical activity is huge. You just need to get off the couch. You got to get out of the chair. We need to be moving more. Our bodies were meant to move in order for us to recover better, to heal better, to have a better quality of life. And this is for everyone. We have to move. So we have to help patients understand what movement is. There are some patients that they're having a rough time. Their movement today is breathing, but they need to understand that's movement. Breathing is movement. It is moving your body. Maybe the next couple of days, all they can do is go to the bathroom and go to the kitchen to get something to eat. Maybe that's all they can do. but that's movement, and help them understand you have to move every day. Maybe it's moving in their bed. That's at the lowest, end of movement. Movement occurs every day, and then you take it from there and you move a little bit more, and maybe then you can go out for a walk, and then you can, um, do more extensive exercise and physical activity. And physical activity is walking the dog. It's I can tell you my physical activity. I'm a chicken farmer, so it's going out and taking care of my chickens. I'm a beekeeper, and it's taking care of my bees. I have 3 grandbabies that I watch at least 2 days a week. And let me tell you, from 7 o'clock in the morning till 6 o'clock at night, I literally don't sit down. They are 1, 4, and 5. That is great physical activity. I'm on and off the floor 20 times, and we were outside because I believe they should be outside all the time. It's playing pickleball with your neighbors. It's some kind of activity that you are having your body go through. Yes, it needs to be safe, but it needs to be there every day for a lifetime. And we have not done a good enough job with that. We're teaching patients that, okay, well, you can do your exercises, 15 minutes, 20 minutes, 30 minutes, that's all it's going to take. And a patient will say, well, I wasn't able to do my exercises for a couple days this week. No, that's not good. That's not good. We need to work. We need to do something every day. So there's exercise, there's physical activity, there's movement snacks, we call it. So 5 minutes, 10 minutes of a quick move. Maybe it's just going up and down the stairs. Maybe it's doing some squats. Maybe it's just doing a quick walk. We need to find ways to incorporate movement within our lifestyle every single day. And I think when we do that, we will see better outcomes with patients as well. And we need to help the physicians, and again, the physician extenders, all of the medical community, to understand that movement is essential to health. It's just essential.
Totally. And it was so good, your share about how movement is in your daily practice and in the little things. Life is in the little things, and movement can be in the little things too. Um, and loved your share about the chicken farm. It was really, really refreshing to hear. And those it can click to them too. But coming
Yeah.
back to because professionals should have, as you said before, are going to into this education and getting to referral better to rehabilitation and professionals, physicians. But one thing that raises an important questions, which is about timing. So sometimes, often referrals come and happen once problems become severe. So once the movement is already really, really low. What would you say are some warning signs that indicate that someone should be referred to oncology rehabilitation much earlier in the process?
Well, okay, it goes back to the fact that we need to have oncology rehab consult with every patient at the time of diagnosis. Okay, so there's that. But I go back to that dirty dozen. So think about what the dirty dozen is. Are you feeling tired? You had even mentioned this. It's a different kind of tired. You sleep and you don't even feel better after sleep. Are you having any just weird feelings of tingling, or you're not even sure what in your hands and feet? But it's not just, polyneuropathy is not just hands and feet either. It's the vestibulocochlear nerve. So now I'm feeling a little bit dizzy. I'm having some balance issues that I never had before, or you're having some incontinence issues because it can be affecting that as well, or other pelvic floor issues, any kind of pain or um, just weakness. Boy, I just can't do the thing. I can't lift my grandchild like I could before. I can't mow the lawn the way I used to be able to push the lawnmower. I can't do that anymore. Or you're feeling just, gosh, I just feel this fullness, in my arms, and my ring doesn't fit anymore. I can't get my ring on. It's those early stages of every one of the adverse effects. I just feel so tight. I've been having radiation, and now, I just can't reach back to hook my bra. I can't reach back behind my back. I mean, it's all of those little things. And if we help patients understand that I'm feeling teary all the time, I'm crying very easily. It's that potential depression, or I'm just so anxious. I just don't even want to go out and meet friends because I'm just nervous. It's all of those little things. We take the our dirty dozen and think about all the beginning stages of each one of those. And that's what patients need to do. If you feel any of that stuff, you have to let us know. So if we consult with them to begin with and say, call me, call me. If you're feeling any of this, call us and we will get you in right away, so that we can treat it early. Early detection and early treatment, better outcomes. A friend of my friend and colleague, Dr. Laura Boatwright, always says, medicine adds years to life, rehab adds life to years. And that is so true. We can make everyone's life better, the quality of life better. We can help you if we know about what's happening early. So tell us early what's going on.
That's really that phrase really sums up how we should view things, and how patients um, have this position too into letting the professionals know, and not don't overlook their symptoms. But you've mentioned education and how important it is, and you've also contributed significantly to the education side of this field, particularly through your guidebook for clinicians. You co-authored Oncology Rehabilitation, a comprehensive guidebook for clinicians. What motivated you to create this ebook, and what gap in oncology were you hoping to address?
Well, I brought it with me, so I have to show it. Here's our textbook, if you can see it. We're so proud of this. We're so proud of this. Um, so this was truly a labor of love. Dr. Chris Wilson, Dr. Lori Boatwright, and myself are the co-editors, and we have authored and co-authored some of the chapters. But we recruited 56 authors from 17 states and 4 countries for this book. And we worked with Elsevier Publishing Company. They were just wonderful to work with. It's 35 chapters, 802 pages. I love all these numbers. Anyways, we're just so proud of it. And the gap that it was really filling for us is there was not a textbook out there for physical therapists, by physical therapists, that we could literally take right into the clinic. And if you have a breast cancer patient, open up that chapter and it'll tell you how to treat that patient. I mean, it's very specific for treatment to many different diagnoses, as well as understanding all of the adverse effects in every single system of our body. So that's part of it. Now, I want to do a shout out to Dr. Michael Stubblefield. I know he has worked with your organization as well. He's just a gem. He's a gem in our field. He has a great book called Cancer Rehab, and that's really the first textbook that came out. And we love that book. We recommend it to all of our students as well. And he's had several editions. But our book is very specific for clinicians working with patients. It just fills that gap of knowing what to do. We've had great success with people purchasing our book because it's also for residents. So we have an oncology rehabilitation residency through our national organization. So those residents always purchase this book. We have a specialization, an oncology rehabilitation specialization, again through our national organization. So this book prepares people for that specialization exam, but it's not just for physical therapists. Everyone can benefit from this. Occupational therapists, exercise physiologists are buying it, a lot as well, for nurses and doctors also, just to look at the big picture of what we can do in oncology rehab. So we believe it has filled a great gap, and we're very proud of it. So thank you for letting me talk about it.
Thank you for bringing it up, and I'm sure it's a great reading for everyone that will dive onto it. One of the themes that really stands out in your work is the idea that survivorship is about much more than survival statistics. And it's more about living longer, not just about living longer, but restoring function, dignity, confidence, and quality of life. How do you see oncology rehabilitation transforming the future of cancer care?
Well, it's already working. We're already transforming it in little ways, and we're just growing and growing. I like to talk about it in terms of the 5 levels of prevention. This is one thing that I teach a lot in all of our educational programs because I really believe oncology rehab clinicians should be involved at all levels, significantly involved at all levels, and that will also help transform the future of cancer care. So when I'm referring to the 5 levels of prevention, I'm referring to primordial prevention, which is basically the decreasing the risk of cancer in communities. So it's kind of community wide. So we really encourage our students and colleagues to become part of your community. Sit on township and city boards and help to develop walking paths that are safe and accessible and free for the public so they can walk and take walks and ride their bike and you know, push their grandbabies around. So make those walking paths or bike paths, again, accessible and safe and free. Bring farmers markets to areas where there are food deserts, anything we can do at that level. Number 2 is primary prevention. And this is the area that I'm really involved in right now. I really believe this is the next step for oncology rehab clinicians to really dive in and help with primary prevention. So prevention of cancer from even occurring at all, but also prevention of recurrence of cancer, which is so important. And in fact, I have developed a program that I'm writing another book about right now, and it's called The Sacred Six. Again, I have all my little tchotchkes here for you. So I have a little block that I give to students when I'm teaching. And so sacred is really an acronym for spiritualizing. So it's about spiritualizing. The S is spiritualize. Then A is associate. Make sure I've got this right. And the C is consume. So associating is associating our relationships. Consuming is consuming with all of our senses. So we need to be very careful about how we're consuming. Then it's R is rest. So that's sleep, the sleep that is desperately needed. E is exercise. And then the D is to decompress. So that's my little block. So the sacred 6 are really about lifestyle behaviors that are essential for primary prevention. The third prevention, so it's primordial, primary, and then secondary prevention is really prehabilitation, which we've already talked about, preparing patients before they start treatment. Tertiary prevention is where we live most of the time. So as rehab clinicians, we are treating the adverse effects of cancer treatment, and that's where we live most of the time right now. But I want to see us expand out into all 5 of these areas. And lastly is quaternary prevention, which is really decreasing the over-medicalization of care. And we need to be part of that. We need to be setting on hospice boards and palliative boards and helping make those decisions and being part of rehab navigation. So I really feel like if we are going to really transform oncology rehab, we need to be part of all of those areas.
Totally. And coming back a little about the guidebook still, what I find powerful is that this vision in your guidebook and in your work too expands across the entire cancer continuum. So not only after the treatment ends, the guidebook covers this from rehabilitation, as you've said, to long-term survivorship and palliative care. Why is it so important to stop viewing rehabilitation as something optional or secondary?
Gosh, great question. And it's really very simple. It's about quality of life. We need to help people improve their quality of life. We need to empower patients to take back their life, to own their bodies, to own their lives. Cancer can be a huge wake-up call for patients. It was for me reflecting on, wow, what is really important in life? At my diagnosis, I didn't know what my future held, and most people don't. We have no idea what's going to happen after this point. So you really start doing a lot of reflection on what really matters, who's really important in my life, where do I need to be spending my time. There's an incredible spiritual side to cancer that is profound, and I really feel like we need to make sure that everyone has access to oncology rehab so we can help patients gain back that control of their lives. For the 20 years that I've been treating patients with a cancer diagnosis, they all say the same thing. They've all had these aha moments. And oncology rehab can be part of that transformation, helping them and guiding them to own their bodies again.
Yeah, absolutely. I wouldn't say it best, but you have your point of view, have gone through it, which is so powerful. If we embrace that philosophy, oncology systems would probably look different than we see today. Totally. If you could redesign oncology care from the ground up, where would rehabilitation and supportive care fit into the patient journey?
Oh, visioning is so much fun. Um, so from the ground up, of course, oncology rehab would be essential standard of care. Every patient would see an oncology rehab clinician at the time of diagnosis and then treat as needed. Not everyone needs rehab, but it's helping people become educated, understanding when they need us, treating them as they need us. Everyone needs education. Everyone needs an exercise program. But then it goes further than that. What we're really trying to promote now is that not only going through the treatment, the patients need to be screened every 6 months. We believe that there should be a screen for here, like we are asked to go to the dentist every 6 months here. So we think you should come to your oncology rehab clinician every 6 months as well. Because I've talked about earlier, some of those adverse effects don't occur till later. There's late effects, and we need to catch those early. So if you are screened every 6 months, we can make sure that there's nothing else happening, treat it if needed, but keeping your quality of life at the highest level possible. This is a time also, if we're continuing to see patients regularly, that we can really teach about primary prevention and prevent that recurrence of cancer or prevent another primary cancer from occurring. We need to really be part of that. There's something else I have to add here that I have been working on for quite a few years. I have been studying it and lecturing on this and talking to physicians about it. And this is about following patients' inflammatory markers. I really believe this is a gap that is huge within this cancer care area. So it was said best we have a national meeting. It's called the Combined Sections Meeting every year here in the United States. And there's always a keynote address. And in 2023, Dr. Field Forte had her address was absolutely wonderful. But one of the things she talked about was precision measurement. She said measurement is the heart of precision. And how can you have precision practice if you don't have precision measurement? We have to measure everything to see if what we're doing is making a difference. And now she was talking about physical therapy in general. To me, this totally fell into this area of oncology rehab. We're not measuring inflammatory markers, which is the basis, it's the foundation of cancer. Inflammation it increases not only with cancer, but with the treatments for cancer. Then on top of that, if you have inflammation secondary to comorbidities like diabetes or heart disease or obesity, your body is this totally inflamed body and it's affecting every single organ in our system. We need to start keeping track of that. Now, the issue is, because as I've talked to physicians and tried to get them to order inflammatory markers on every single patient, they'll say, well, which markers? Which ones do you want me to order? Because it in no way is standard of practice at this time. But the research is coming out more and more every day. There's some great articles now where they're actually finding very specific inflammatory markers for certain diagnosis of cancer. And so that gives me hope. We also know that inflammation, it accelerates tumor progression. It just increases metastasis. The inflammation is the basis for that. It actually will also drive genetic instability. And so then you have the more genetic mutations. What we also know, there's research out there that shows exercise decreases inflammatory markers. There's great research out there for that. Good, healthy nutrition decreases inflammation. Positive social relationships decrease inflammation. You decrease stress, you decrease inflammation. You increase better sleep, you decrease inflammation. So it's out there. It's about putting it all together. And my dream would be that from the day of diagnosis, you start with getting those inflammatory markers before treatment starts, and we follow that. And we want to do great interventions as oncology rehab specialists. Lifestyle medicine is part of what we want to do. But how do we know if it's working if we can't measure it? If we're not measuring it and we're not seeing a decrease in their inflammation, we're doing something wrong. We're not doing enough. We have to have that as a basis for our treatments. As you can see, I'm very passionate about this because I really believe it's a really missing key to our treatments for cancer.
Yeah, I can totally see it. And I think that redesign would probably help for sure. The inflammation is a big part of it. As you've mentioned, pretty clear. Let's dive a little more into exercise, movement, and integrative oncology. One of the most exciting shifts we've seen in recent years is this growing recognition that you've mentioned now that exercise movement is part of evidence-based oncology care. Being this recognized and having its importance, why is movement, why do you think movement is so powerful, psychological and physiologically during survivorship?
Well, it just is. Movement is medicine, movement is life, movement is essential for survivorship. Again, as I mentioned before, we need people to take control back of their bodies and feel like some people feel like their bodies have failed them and they become afraid to move. And then we have family members, oh my goodness, when a patient will come in and say, well, my husband says I shouldn't golf anymore. It's like, bring your husband in and let me talk to him because yes, you should be golfing again. We need to help people to not be afraid to move, to understand, but understand how they can move, how they can safely move. They need to understand how to take their vital signs. And we need all of us, not just oncology rehab clinicians, but also, again, the physicians. Everybody needs to be talking about the importance of exercise and the importance of movement. I have a good example because I had a patient who was diagnosed with breast cancer. She came into the clinic and she was very angry when she came into the clinic. She had, her life just fell apart in front of her with this breast cancer diagnosis. And she said, I don't even know why I'm in here. I haven't even had surgery yet. This is a waste of my time. That was how she greeted me. And I said, okay, honey, come on, sit down, let's talk. So, I spent like an hour with her. We talked a lot about her treatments, but I also did baseline studies on her. I did a treadmill test. I wanted to see where she was starting. And I talked to her about starting an exercise program. And she did. She grabbed it. She started exercising. I saw her after her surgery. I saw her a couple times during radiation. Again, we don't have to see people several times a week. It depends on, where they're at, what adverse effects they're having. I saw her a few times during chemo. And then I didn't see her until I ran into her at the Hallmark store. About 9 months later, she came up to me, gave me a great big hug. She was feeling great. And she said, oh my gosh, I haven't felt this good in years. She said, my daughter and my sister and I started doing races. So, of course, there's all sorts of races for all different organizations, and whether you're doing a walking race or running race. But the three of them had started doing several races. She was having so much fun. She looked wonderful. I mean, every part, her hair had grown back, her skin looked great. She said she had never felt better. And so that's the example of what it can be, if we provide people with the knowledge and the opportunities to increase their exercise.
That's good. You've mentioned it, and it's such a particular case, but every person is different and their experience is different too. But rehabilitation should be there. How can clinicians better personalize exercise recommendations rather than giving generic advice, which sometimes can occur?
Yes, and I really don't like that. Generic advice, we try to tell people generic advice is a waste of time. And all it does is make people feel guilty because if you give them, I cringe when people will say, yeah, I was at this office and they just handed me this piece of paper with these exercises and said, go home and do them. Or they told me, yeah, just go start walking. Oh my goodness, we can't treat patients that way. They need very specific programs designed just for them. Every single person's body is different. Every single person's experience with cancer care and their comorbidities is different. Everyone needs an individualized program. It needs to be safe. Patients need to be able to know how to progress and regress that program because they're going to feel great some days and not great some days. They need to know how to take their vital signs. We need a very specific prescription. So what we need to do is make sure that if you as a clinician in whatever field you're in, can evaluate a patient, do the baseline studies, and set them up with a good prescription, telling them again how to progress and regress and how to take their vitals, then please do it. If you cannot do that, it's very simple, then you refer to somebody that can. There shouldn't be no generic advice. It should be either you do it yourself or you refer to somebody that can, so patients are getting the best help they can, so they can truly fill their life with joy and happiness and live their best life.
Uh, Absolutely. And this is where integrative oncology meets. So it becomes especially important because no single discipline can address survivorship alone, not only movement or exercise. We can talk about other points of and aspects of life too. From an integrative oncology perspective, how do rehabilitation, lifestyle medicine, nutrition, and a psychosocial care can complement each other?
Wow, that's just a great question. And truly, all of us are needed equally. There's not one that's more important than the other. The most efficacious treatment for a patient would be to have access to every one of those things you just talked about. We all need to be part of it. We all need to be sitting at the table equally. I like shared decision making with the patient, with all of the providers, all of the stakeholders. We need to be together. Cancer affects every single organ system in our body, and it affects our family and our caregivers. So that all needs to be taken into consideration when we are treating a patient. And it's not just treating them now and for what's happening with them now, it's helping them to understand the lifestyle that will help them to live their best life again, to live with intention and be as healthy as possible through the rest of their life. One of the other areas that I've been studying a lot about lately is the information coming out about cancer being a metabolic disease. That it's really about mitochondrial dysfunction, that every cancer cell has mitochondrial dysfunction, and we really need to dive that deep within the cells to really help patients heal and prevent cancer. And we know that mitochondrial dysfunction then leads to somatic mutations. So how do we get to that mitochondrial dysfunction? Well, inflammation causes mitochondrial dysfunction and back and forth. Immune system collapse causes mitochondrial dysfunction, and it goes back and forth. So it's so wonderful. We are at a stage now where all of this information is coming out and we can work with all of it, but it takes a village. It takes a tribe. We need to all be part of that patient's world in order to give them the best and healthiest life.
Totally. And honestly, this is one of the reasons why we created our advanced certificate in lifestyle oncology at the European School of Lifestyle Oncology, because we kept seeing this growing need for healthcare professionals to understand cancer care beyond treatment alone and really integrate all pillars of lifestyle medicine. And we realized professionals wanted more education and needed that education too around exercise, nutrition, emotional well-being, lifestyle medicine, and how to integrate all of this and how to support the patient better. There's still many places where all these areas are taught individually, and they need to be working together, and clinicians need to integrate this in a practical way to help the patients better. And listening to you today really reinforces that and how necessary it is that this multidisciplinary vision becomes not only a vision, but more and more and so on has reality too. As we begin to close this episode, I would love to leave both healthcare professionals and listeners with a broader reflection on where oncology care is heading. Is there one message, if you could give to our audience, you wish every healthcare professional dealing with cancer patients could hear? What would it be?
Wow. I guess I would say it very simply, we are better together. We have to work together as a united, compassionate, transdisciplinary team so that, again, all those stakeholders are sitting around the table with the patient and working together to provide them with the best care. It will help patients to have a sense of trust in us, a sense of confidence that they know they're receiving the highest quality of care. There are patients that will say to me they feel like they aren't heard, that nobody's listening to them and what's going on with them. Well, if we are working together, we can hear those patients' needs and treat every patient individually. Every patient is an individual, and all of us are important. We're better together.
Yeah, such a powerful message. I would say so. And despite the challenges we still face and that still exists in survivorship care, there's also this great growing movement pushing this field forward. I truly believe that, and we can totally see it. What gives you hope when you look into the future of oncology rehabilitation and survivorship care?
Well, first of all, you give me hope. Your organization is wonderful. You guys are doing great stuff. So thank you
Thank
for
you.
being out there. Um, I have just been blessed with watching the evolution of oncology rehab for many years. I have been a physical therapist for 47 years. So I have watched it from really its inception to where it is now, and it is so exciting. I do believe, and you're this is part of your theme too, is that oncology rehabilitation is revolutionizing cancer care. I love that. Um, there's great education out there that's increasing all the time. There's wonderful evidence-based practices going on. There's huge amounts of research that just keep coming, more and more publications every day. Therapists that are not only interested in treating this population, but also, I actually had a therapist tell me the other day who I'm mentoring that she wants this to be her legacy. You know, she wants to leave this legacy of working with this population. I just love it. So it is improving all the time. We are also strategically working to make sure that there's oncology rehabilitation clinicians at the local, state, national, and international levels on committees and boards that can help with decision making, to make referrals easier, to make oncology rehab a standard of practice, to educate clinicians. So we need to be out there participating at all different levels. I just believe that oncology rehab is evolving rapidly and with purpose. And it's redefining what survivorship is. It's just great. We have a great future ahead of us.
Totally. And you're one of the persons that has been doing the differently. And thank you so much for that. Not only your practice, but this conversation that meant a lot to us and was really thoughtful and incredible to hear and to participate to. Thank you to everyone listening to the Oncology Revolution podcast. If this episode resonated to you, please share it with someone who might need to hear it. Until next time, take care and stay connected.
Thank you very much. Thank you.